All right. Hello, everybody, and welcome. It is 1:30 Pacific time. So we're going to go ahead and get started with the webinar today. Hello, my name is Amy Forbes. I'm the training manager with the Northwest Mental Health Technology Transfer Center, or otherwise called MHTTC. Welcome to today's webinar, PrEP Talk, Enabling Mental Health Professionals to Lead in Prevention with Dr. Joanne Stekler. And please know some important information. This webinar is being recorded. A certificate of attendance will be emailed to those who registered and attended, and we are not able to offer CEUs for this webinar. I'm going to give a brief overview of our network and some important information before we get started. The MHTTC is a nationwide network supported by the Substance Abuse and Mental Health Service Administration, or SAMHSA. Our network includes 10 regional centers and a network coordinating office. And you can see in the pink highlighted circle, that's the Northwest MHTTC, and we cover HHS Region 10, which includes Alaska, Idaho, Oregon, and Washington. Our goals at the Northwest MHTTC are to support mental health-related evidence-based practices, heighten awarenesses, knowledge, and skills of the behavioral health workforce, foster alliances and address diversity of training needs, and to share free publicly available training and technical assistance. Our areas of focus are in evidence-based practices for psychosis, which include CBTP and assertive community treatment. We also provide training on a variety of other topics. Please do check out our website where you can register for free webinars or learning communities, watch a recorded webinar, take a free online self-paced course with healthy knowledge, sign up for our weekly newsletter, review our resource library, or listen to our podcast called Putting It Together. And with that, I'm going to hand it off to Lori, who will be sharing some information about the AETC.
Hi, everyone. So I'm Lori Sela. I'm the director of the Mountain West AIDS Education and Training Centers, known as the AETC network. We are part of a national network that is funded by HRSA, the Health Resources Services Administration, and we are the training arm of the Ryan White Care Program. We're funded under Part F, for those of you who might be familiar with the Ryan White Care Act, and our goal is to create and expand the HIV workforce and to have a workforce that is culturally and clinically competent to provide prevention, diagnosis, and treatment services related to HIV and related conditions such as STIs and viral hepatitis. All of our trainings are free. We provide webinars, we do on-site programs for individual clinics, we offer on-demand education through our website, we provide clinical consultation, preceptorships, and have a variety of programs available. We organize conferences. We serve 10 states. We serve both Region 10 and Region 8. So that covers Alaska, Colorado, Idaho, Montana, North and South Dakota, Oregon, Utah, Washington, and Wyoming, and those are shown in orange. You could go to our website at mwaetc.org if you'd like to be added to our newsletter list to find out about upcoming trainings, if you want to request a training for your own organization, or if you want access to resources, on-demand training, or if you want to learn more about any of these things. So thank you. And that's just our disclaimer slide that our funder likes us to put in, showing that we are funded by the HRSA administration.
Thank you, Lori. I'm going to go over a little bit for today's webinar. We will send a link to the webinar recording, slides, as well as your certificate of attendance within a couple weeks after today's event. For communication during this event today, please do use the chat box to reach out to our staff, or you would like to share respectful comments, greetings, and observations with everyone. Please do use the Q&A box to type in your specific questions for our presenter. You can do this at any point throughout the presentation, and we're going to be monitoring the Q&A box to facilitate answering as many questions as possible at the end of the presentation. Also, at the end of the presentation, we will send out a link to our survey. Please know your feedback is very important to the work that we do and the content we provide. We are required by SAMHSA to conduct this survey, yet they do not have an official position on our content. And I just want to share upcoming events. The fourth and last presentation of our sexual health series will be on July 16th with Dr. Tim Menza. Please do register for the event if you have not already done so. And I'm happy to welcome and introduce you all to Dr. Joanne Stekler, who began her career working to expand routine HIV antibody testing and access to pooled HIV nucleic acid amplification testing to diagnose acute HIV infection. Her current work is evaluating the feasibility of implementing point-of-care nucleic acid tests for HIV diagnosis and treatment monitoring in community and clinical sites in Seattle. Her other interests include HIV pre-exposure prophylactics, or PrEP, and use of technology for HIV prevention. Dr. Stekler started the first community-based PrEP clinic in Seattle in 2013 and the first teleprep clinic in 2015. Through collaboration with the Washington State Department of Health and Mountain West AETC, she has been working to expand access to PrEP to reduce healthcare disparities among populations disproportionately impacted by HIV. Dr. Stekler, we are thrilled to have you here today, and I will hand everything over to you.
Great. Thank you so much, Amy. I'm going to share my slides now. Does that look okay?
Yep, looks great.
Great, thank you. So again, thank you, Amy, for the introduction. I'm going to talk about HIV pre-exposure prophylaxis. And my goal in this is to give everyone here a bit of information about how to talk about PrEP with your clients, to talk about PrEP with, so that you may be able to refer or recommend that someone seek care, and how to support people who are on PrEP. This is a slide deck that I often use to talk with folks who are prescribers of PrEP. So I may jump through a lot of slides that may not be relevant as much to folks who are in that early part of screening and conversation and wanting to make sure that you have all the correct information. So you'll have all of these slides. If you are someone who is a prescriber and you really want to know all the details, these slides will be available to you, and don't worry if I'm jumping too quickly through some of the slides later. My disclosures are that because we're talking about medications, that I will talk about commercial products, as well as some off-label and investigational use of products. The U.S. Food and Drug Administration allows us as physicians and prescribers to write prescriptions for medications that are not within their FDA approval, and that is common with PrEP. And I have no personal conflicts of interest or relationships with financial entities to disclose. So that's me. Before I move on, I'm hoping that we can get a sense of who you all are. And I have a poll question and then a word cloud question. Peyton, if you could launch the poll first. Thank you. So first, I want to know what your roles and responsibilities are for PrEP. So what I'm interested in is knowing what in your current role is. What's your role in HIV prevention? Do you prescribe PrEP? Do you discuss PrEP with your clients? Do you refer? Do you support those who are on PrEP and talk about medication taking? Or is it your feeling that you don't have any role and responsibility in HIV prevention and pre-exposure prophylaxis. So I always describe these things as sort of popcorn. It's when you put your popcorn in the microwave, and when it starts to slow down, there's a hand raised. I don't know if we want to. There may be, you may have more than one of these responsibilities. So what is your primary responsibility? So the majority of folks here are supporting people on PrEP and discussing PrEP with their patients or clients, and a number of folks who are of the feeling that they don't have any role in HIV prevention. So I'm going to end this poll. I'm going to hope that I can change the mind of those people who think they have no role in HIV prevention. Oh, sorry. Now sharing the poll results for you all to see that too. And then, Peyton, if we can launch the cloud question. So thinking about that role that I need to close that. Thinking about that role you just talked about. So what is it that you would need to be more successful in expanding access to PrEP in your organization? And for those of you who do clouds, if you can try and keep your responses to just a few words, you're limited 3 words, but you can put those 3 words in, or 3 different words in 3 times. So if you have sort of more to say than just 3 words, feel free to throw it in the chat. So I'm seeing some chat as well, in addition to that cloud that you're seeing form. So young population, information, funding, need more information, need to know about resources, need more education. More information about talking with teens, more knowledge. Okay, so if you're seeing the same word cloud I'm seeing, you're seeing that many of you are saying that you need more education, more support, and more training with some more information and resources. Great. Thank you for contributing to that. Okay. Oh, now I need to share again, don't I? Sharing again. Okay. This is just our standard AETC slide talking about how data is often related to racism. So the epidemiology of HIV is related to racism and not specifically race, although I don't share a lot of epi data in this talk. But what I am going to talk about is, for those of you who aren't PrEP experts, we'll talk about what PrEP is, how well PrEP works, a lot of the concerns that you may have or your patients may have about side effects, about sexually transmitted infections, about drug resistance, and a lot of the other concerns that they may have and that we may have. And then I will spend less time talking in this talk today about actually how to prescribe and how to monitor, although I'll give you all an overview of that. So first, what is PrEP? There are a few things that we've talked about for years. One is PEP, or post-exposure prophylaxis. The other is PrEP, or pre-exposure prophylaxis. And they differ in terms of when someone is likely to be exposed to HIV or possibly exposed to HIV and when they're taking medicine. So we've known and given PrEP or post-exposure prophylaxis for many, many years. And what PrEP is if someone is exposed or possibly exposed to HIV, either through sex or needle sharing or through an occupational exposure, they are recommended as soon as possible to seek care, and that as soon as possible can go out to 72 hours, but really it is ideal to get someone into care within the first 24 hours after the possible exposure. And then someone who has been exposed may take medicines, and usually 3 HIV medicines for 28 days to prevent them from getting HIV infection. So that's post-exposure prophylaxis, where you have a potential exposure, you're not on any medicines, and then the next 28 days, you'll take 3 HIV medicines. Now, PrEP, pre-exposure prophylaxis, is intended for someone who has frequent and regular potential exposures to HIV. So they are taking HIV medicines, and we'll talk about what those medicines are in a second, taking regular medicines, and they might get exposed multiple times in a week, but they are protected if they're taking the PrEP. There is another way to take HIV pre-exposure prophylaxis where someone may have only occasional exposures, and they will take their PrEP medications 2 to 24 hours before an exposure, and then for the next couple days after the last time they've had sex or any potential for HIV transmission. But then during that period of time where they may not be exposed, they won't be taking their medicines on a daily basis. And I'll talk a little bit about that as I move forward. Unfortunately, we're sort of the Centers for Disease Control and Prevention are a little behind in terms of their guidelines, although what I've just told you about exposures and that timing has not changed. I actually recently seen the updated guidelines that we should be seeing by the end of this year. And really, they're going to emphasize what I said a little bit earlier, that even though there is a 72-hour window for when someone has a potential exposure to when they should be seen, even though the window is 72 hours, really the recommendation is at least in the first 24 hours, and it's really as soon as possible. So your counseling message is if someone says they had a potential exposure, is to encourage someone to seek care, whether that's at the primary care provider or your prescribing or a local emergency department, a clinic. It's an urgency. They should go and seek care sooner. So in terms of who and how to refer for post-exposure prophylaxis, if someone is telling you about a potential exposure. So if someone is on HIV pre-exposure prophylaxis or PrEP and they've been taking it, you do not need to refer them for post-exposure prophylaxis. But if they're not on PrEP or they've not been taking their pills every day, you might consider referring them. The real risks are for people who've had condomless, insertive, or receptive anal or vaginal front hole sex in the last 3 days. Again, sooner rather than later for that. But again, the window is 72 days. So here are the key messages that I want you to have. One is PrEP, post-exposure prophylaxis is 3 medicines taken for 28 days after an exposure. 2 of the 3 medicines are the same medicines that are in PrEP. PrEP should be covered by insurance or by medication assistance programs. And if you're going to go on PrEP, do it sooner rather than later. I think I've now said that 5 times. And you can go, if you are thinking about PrEP, you can go on it right after that 28-day course. So taking a course of post-exposure prophylaxis does not mean you're going to have to jump through any additional hoops in order to get PrEP. And it's really a discussion with someone about what they perceive their risk to be, depending on who the exposure is with. So there are very few times that I actually say to someone, you have to go on PrEP, but it's often this conversation that has, and doing some shared decision-making with people. Okay, so that was PrEP, post-exposure prophylaxis. Now I'm going to talk mostly about pre-exposure prophylaxis. And again, pre-exposure prophylaxis, just like PrEP, is HIV-negative people taking HIV medicines to prevent them from getting HIV infection. And we have three different ways that someone can, three different medications or combination medications that people can take as of June 2024. The first, the one that was approved earliest in 2012, was daily emtricitabine tenofovir disoproxil fumarate. That's a mouthful, I know. It is, you'll see it abbreviated in my talk as FTC, that stands for the emtricitabine, and TDF, tenofovir disoproxil fumarate. It's available as a brand name Truvada, but it is also available as a generic. I will say brand names in this slide. I will try not to say brand names in the future part of this conversation. So remember, FTC-TDF is Truvada and is available as a generic. It requires someone to have an estimated creatinine clearance. That's a measure of kidney function that is at worst mildly impaired. There is a second combination pill that was made by the same company, that is emtricitabine tenofovir alafenamide. It is also FDA approved to be taken every day. I will abbreviate it as FTC-TAF or TAF, and that is brand name as Descovy. It is currently FDA approved only for cisgender men and transgender women who are at risk for HIV from sexual exposures. The reason for that is that the preliminary studies that were done were only done in cisgender men and transgender women. And there's a large study that is currently being done in cisgender women that is expected to release results within the next year. It is a little more forgiving in terms of kidney function, which I'll talk about in a bit. And then more recently, we have our first injectable medicine, that is injectable cabotegravir, which is brand name Apretude. It is approved in all populations who are at risk from HIV from sexual exposure. There is another medicine or another way of doing pre-exposure prophylaxis, that is the dapivirine vaginal ring. That went to the FDA for approval, but because the efficacy wasn't as good as the pills or the injection, it has been withdrawn. But there are other medicines that we can talk about that are likely to be coming down the pike in the next year or few years. This is a busy slide. I'm not going to go through it all. What this shows, though, and all but the very last row down here, everything above that are all of the studies that were done from the early 2000s till they reported results in 2010 or so. All of the studies that showed that primarily FTC-TDF worked to prevent HIV infection. There were a lot of them. They were done in cisgender men, small numbers of transgender women, lots of cisgender men and women having heterosexual partners, some in discordant partnerships where one of the partner was positive and one was the negative. Lots of different studies, large studies that were done. The one at the bottom is one that I'll go into detail a little bit more. That was the study that was done in cisgender men and transgender women that was comparing daily oral FTC-TDF and daily oral FTC-TAF. This slide is mostly for your reference, though. The main point that I want to share with you about all of these studies is on this slide. This slide is for those of you who like your data in table form. And what it is it has some of those first few randomized clinical trials that were done looking at FTC-TDF and ordered by how well they showed that FTC-TDF protected people from HIV infection. The study that showed the highest efficacy in the modified intent to treat analysis is up at the top. This is the Partners PrEP study that was done in discordant couples that was based out of the University of Washington. And at the bottom here are two studies that were done primarily in cisgender women, which showed no efficacy at all of FTC-TDF. But what I have here in this right-hand column is when they looked at the participants in these studies who were randomized to the arm that was supposed to be getting the active drug. And they looked at blood samples and whether they could detect any amount of medication. That up here at the top, with the study that showed the highest efficacy, the highest proportion of samples had medicine detected. And in these studies in which PrEP looked like it had no efficacy at all at preventing HIV, that only about a quarter of the samples from participants who were randomized to the active medicine, only a quarter of those specimens had any detectable medicine in them. Okay, I said that was for people who like their data in tables. This next way of looking at it is if you are someone who likes your data as a figure. Same studies, same data. On the x-axis here is that proportion of blood specimens that had tenofovir detected. Up here is the efficacy. How well did PrEP work to prevent HIV infection in that modified intent to treat? And you can see there's a really nice relationship between taking your medicine, taking PrEP, and how well it worked. And so it's based on these data that allow me to say, and this is something you could share, is that PrEP works well if you take it. PrEP doesn't work so well if you don't take it. And how well is that? Well, there have been a couple studies that have looked at that, and why we say that PrEP is really effective in real life. So up at the top left is data that came from the iPrex open label extension, OLE. So iPrex was the first study to report results. It was done in cisgender men and transgender women. And in the people who continued to be on PrEP after they knew that it was effective, that there continued to be some HIV infections. And when they looked at the blood samples from the people who were continuing in the open label extension, that there were no infections in people whose blood levels looked like they were taking their PrEP at least 4 days a week. There were fewer infections than in people even who were looked like they were taking it only 2 to 3 times a week. And this is compared to about a 5% incidence in this population among folks who had no medicine detected at all. Down here to the lower right is more recent data that Jeannie Marazzo, who used to be here at the University of Washington before she went to Birmingham and now has taken over Tony Fauci's role at NIH, has recently published a similar analysis looking at the amount of tenofovir in blood of cisgender women and the incidence rate, showing that if these cisgender women took their pill, looked like they were taking it daily, that had a incredible reduction of HIV in that population. And similarly, there was a dose response relationship. So PrEP works if you take it. PrEP doesn't work if you don't take it. But the other thing that is clear from both these is that PrEP sort of works even if you aren't perfect. So there's quite a lot in this. So first is that it looks like you only have to take your pills 4 days a week for it to be perfect. Well, I'm going to show you on the next slide that even PrEP isn't 100%. And so what I typically say to my patients is that the goal is to take it every day, but we should all be really forgiving on ourselves because doing things every day is hard. And so if you miss an occasional dose, it's not the end of the world. But also, I've had people who have very clearly had other things going on in their lives. There's substance use and mental health issues and all the things that you all do in your daily lives. And so what this slide shows is that even if you are someone who can't take your pills every day, and even only take it a couple times a week, that you can have a significant reduction in the risk for HIV infection. And so even when someone says, I'm just not sure I'm going to take my medicines, that PrEP still may be right for them. There are some risks that we'll talk about in a second for that, but this is the place where we do shared decision making about what the benefits are of preventing HIV versus what some of the consequences. So I typically tell people that based on these data, if you take your medicines every day or nearly every day, that PrEP is more than 99% effective at reducing your risk. And I don't ever say 100% because there have been a number of really well-documented cases of people who became HIV positive despite saying they take their pills every day, having their refills filled on time, having blood levels that look like they should have been protective. And I've given you a few examples of some of these cases of people for whom PrEP failed them, both for oral PrEP as well as injectable PrEP. But we know that there are going to be others who are not written up in these perfect case reports. So PrEP is not perfect, and people should continue to do all the other things that they might do in order to protect themselves from becoming HIV infected. And some of those things include condoms, reducing the number of partners, if they're a cisgender man who has sex with men, topping, being the insertive partner compared to being the bottom or receptive partner, because bottoming has more risk for HIV acquisition. So PrEP isn't perfect, but it does work very well if you take it. Okay. Next, I'd like to talk about some of the side effects, what people should expect when they are taking PrEP, and perhaps how to choose among their medicines. What I'm going to show you in the next set of slides are some data from that Discover trial, which was that slide at the way bottom, which showed the comparison of FTC TDF, that's the older medicine that is to the right, which is the direction you're seeing. It is to the right of your slide over here. Older medicine currently available as generic, newer medicine. And what we've known since we started doing PrEP is that there are short-term and long-term side effects associated with oral PrEP. The short-term side effects are similar regardless of which PrEP medicines you're going on. And I typically tell people that in the first few days after starting PrEP, you may have some number of these minor side effects, including headache, feeling tired, and stomach-related stuff. In most everybody, those side effects will go away in the first few weeks, and very few people have to stop taking their PrEP because of these initial side effects. Sometimes if people have horrible stomach-related stuff, it helps to take their PrEP with food if they're not taking it with food. Sometimes people say that taking it with food makes it worse, but neither of the PrEP combination pills have to be taken with food. The other thing I've heard people say is that sometimes if they take their pills at night, if they get into the routine of taking it when they brush their teeth, if that's a routine that they have, that sometimes they might experience those symptoms, but they're asleep. And so that helps them get through that first few weeks when some of those symptoms might be worse. It is the long-term side effects where the two combination oral medicines differ. Again, the older medicine, FTC TDF on the right, FTC TAF on the left. And the main side effect that we tell people about with FTC TDF is bone and kidney changes. So with the bone changes, they are at a 1% difference. They are a chance of having 1% change in their bone mineral density. So that is, if that were to continue, that could go to osteoporosis. This is not what we're seeing. There's never been any clinical consequences of people taking FTC TDF for at least the few years that people have been studied. You don't fall, I always say, you don't fall down and break a hip on the dance floor. But if we were to do DEXA scans, that's imaging of that's done to detect osteoporosis, you can see the difference in someone after they've been on PrEP for a year. We don't routinely recommend doing DEXA scans. We do, however, routinely recommend checking kidney function because, as I mentioned earlier, that in order to go on FTC TDF, you could have only some minor changes in your kidney function, but it can make kidney function worse. And so we always, and someone starting on PrEP, we always check their kidney function to start. And depending on if they have risk factors for kidney problems, either they have high blood pressure, diabetes, or other medicines that might make them risk for kidney problems, or they started off their PrEP with sort of that right at the borderline of when they could be starting on this particular medicine, we might check them more frequently. So in contrast, the other newer PrEP medicine tends to increase body weight. So on average, a couple pounds per year. We all gain weight. People who are on FTC-TAF tend to gain a little bit more. And then there can be some worsening of total cholesterol and LDL, the low density lipoprotein, which is the bad cholesterol. So neither one of these is safer than the other. FTC-TDF, again, the generic, is totally safe. And the vast majority of folks starting oral PrEP should start on that medicine unless they have known kidney problems or known bone density issues or some other condition that makes going on FTC-TDF contraindication. The other thing I just want to mention is this strategy for intermittent PrEP. So there was a study that was done. There were a few randomized studies and then some open label where the people were looking at alternatives to daily PrEP. And in this study called ePrGay, people were given FTC TDF tablets only, and they were told to take 2 of those pills at least 2 to 24 hours before sex, 1 tablet 24 hours later, and 1 tablet 24 hours after that. And I share this with you mostly so if someone says, oh, I don't take my PrEP every day, you can say, okay, how are you taking it? And you can say, okay, that's, that sounds totally appropriate, or, that's really not the way it's been studied. This way of taking PrEP also worked very well at preventing HIV infection. It reduced, in this study, it reduced HIV acquisition by almost 90%. Again, most people will say that it's about taking it as prescribed. So again, if you take it the way it's prescribed, it will work. If you don't, it may not protect you quite as well. I think there's one, this is the open label extension. Again, PrEP research has been really interesting because it is one of the few times in research where the efficacy trials, the trials that were done with the research populations who are really highly motivated, where the efficacy, how well did PrEP work, is actually better in the real world. And that's because we know that it works if you take it. So in this open label extension of the strategy where people are taking it 2 to 24 hours before sex, a pill 24 hours later, and a pill 24 hours after that, there was a 97% relative reduction. Again, I'm going to say one more time, PrEP works if you take it. Okay, and then finally, we now have injectable cabotegravir. This, in the research studies, people started on oral medicines of cabotegravir just to make sure it was tolerated well. That's not what's done in the real world. But then it is an injection 1 month after the first injection, and then every injection after that is 2 months later. There's a window of plus minus, total window of 2 weeks, so plus or minus 1 week before and after the ideal injection date. So it has a little bit of forgiveness in terms of getting people in, but that is one of the challenges. But there were these 2 large trials that were stopped early. One that was done by the HIV Prevention Trials Network, or HPTN, in cisgender men and transgender women, and then another large trial that was done in cisgender men, both compared against FTC TDF. Both stopped early because it looked like injectable cabotegravir was superior to oral PrEP. A lot of this is thought due to adherence, and some of that data is continuing to come out from the study as we learn more. But excuse me, this was FDA approved And we are in the process of figuring out how to implement injectable PrEP and who that is right for. And we can talk about it a little bit more if people have questions. Okay, moving on to what people's concerns are. Some of these are your concerns, some of these are the patient's concern. There's a lot of worry when PrEP first got FDA approved that we would be in a place where, as we heard, everything goes. I heard people complain about it. People could do anything now, and that perhaps we might start to see more compensatory behavior that would result in more HIV infections and a lot more STIs. So before I talk about your worries, I want to talk about what the positive things are about PrEP. And there are a lot of them. And it has been amazing to go from a place where I started training back before we had combination antiretroviral therapy, now adequate treatment, and finally a tool that people who are HIV negative can use to protect themselves. The first, and these generally are all around anxiety. So PrEP decreases anxiety. People do use it as an anti-anxiety within their partnerships, even if there's a little risk of transmission. What PrEP has done in discordant partnerships where someone is positive and someone is negative is allow people to talk about this, allow people to talk about their feelings, talk about sort of how condoms and lack of condoms sort of change the intimacy and change their relationship. I mentioned a little bit ago, HIV negative folks now have a tool that is beyond just, I'll get tested regularly, and if I test positive, I'll change my behavior. And it's really allowed us, those of us who do this work, to stop talking about HIV and sexually transmitted infections from a negative standpoint and start talking about is how do you enjoy your sexual lives? We are all sexual beings. Sexual health is a good thing, and we should be encouraging people to have healthy sexual lives. Okay. Now, being a positive person, let's talk about the negative stuff. So one of the things I think we're all concerned about is that we are in a place where there are a lot of sexually transmitted infections, syphilis is on the rise, we're seeing more congenital syphilis, things are getting harder to treat, there's resistant gonorrhea. It sounds like you're going to hear about that in one of the next webinars. But what happens when someone goes on PrEP? And a lot of different things happen. There are some people who don't change their behavior at all. They're just adding on an extra layer of protection. There are some people who recognize that going on PrEP means that they're taking care of themselves, and they actually have decreased risks for HIV and other sexual exposures to other sexually transmitted infections. And then finally, there certainly are people who stop using condoms, start having more partners. And there's always been the question of, is PrEP going to increase sexually transmitted infections? And what this slide is showing you is a meta-analysis. And really the only thing you need to see is this box down here, which shows that among populations who are on PrEP compared to those who aren't, there is a higher rate of sexually transmitted infections. And this is not necessarily a bad thing, because people who are at risk for sexually transmitted infections are also at risk for HIV. These are the populations we actually want to go on PrEP. The other is that there is some modeling evidence that suggests that the more we test means the more that we treat, and perhaps that the frequent testing every 3 months is what is recommended, that we might be able to get a handle on our STI pandemics. The other big concern was about drug resistance. So the medicines that were in oral PrEP form the backbone of our HIV regimens for people who become HIV infected. And so there was this concern as, oh my gosh, we're all of a sudden going to start having more HIV drug resistance, and we won't be able to treat people who live with HIV. And that is not what is happening. Again, what I'm showing you on this slide is data from some of those first studies and looking at who had drug resistance. And there are two lessons here. One is that in those original trials, there were a fair number of people who were HIV positive when they started PrEP. PrEP is two HIV medicines, at least the oral PrEP medicines are two HIV medicines, which is not enough to drop a viral load down to undetectable levels. And so those folks who were truly HIV positive when they started, and they were thought to be HIV negative because they used oral fluid HIV tests that have a fairly long window period. They had been recently infected, started two medicines, and then developed acquired HIV drug resistance. One of the interesting things here is you can see that there are still people who, even though they were on placebo medications, when they became HIV positive, they had a virus that already had drug resistance. This is not all that uncommon. About 1 in 10 folks here in Seattle who acquires HIV acquires a virus that already has resistance to one of the HIV medicines. It is really uncommon to have drug resistance to the HIV medicines that are in PrEP, but it is possible. Okay, the other part is in the people who were truly HIV negative, that there was a slight increase in HIV drug resistance when those people were diagnosed with HIV. That's because if someone is taking their PrEP appropriately, that they're not going to become HIV positive. If they are taking just a little bit, a few times a week, there is the chance that they might get a little bit of drug exposure and acquire HIV drug resistance. So there is that little negative associated. But when we look at it from a risk-benefit balance, again, doing shared decision-making, that the benefits, the great benefits, really outweigh the risk of drug resistance. We'd much rather prevent about 10 new HIV infections than worry about that one case of drug resistance that we're going to cause with them. For those of you who have transgender patients, there's been not a lot of data until recently. We knew very early on that PrEP has no impact on hormone levels. That's something that people are very concerned about. Because if I start this medicine, is it going to change how my hormones work? And the answer is no. And we know that for certain. We were worried that the opposite might have been true, that PrEP, that hormones might have changed people's PrEP levels, making PrEP not work as well. And there is increasing evidence from a study called the I-Breathe study that isn't true at all, that people can continue to take their gender-affirming hormones and their PrEP, and PrEP will work just as well. That being said, I think people are still a little cautious about this and would not at least recommend that 2-1-1 dosing for folks who are receiving either feminizing or masculinizing hormones. So that 2-1-1, again, is 2 pills, 2 to 24 hours before sex, 1 pill, 1 pill. There's still lots of sort of concerns about how to increase access for folks who are transgender because concern about side effects, lots of stigma and trust of medical providers, which is, I'm sure, true of your patient populations as well. And then we've talked about co-locating PrEP services with gender-affirming care services, just like you probably have been in discussions, you may have been in discussions about how to co-locate PrEP services with your behavioral health services. Okay, this is the section that starts all of the details about how to prescribe PrEP. I will go through this in detail in the places that I think might be most helpful. And if people have questions, you can ask them of me if I've skipped over a section you have a question about. This slide shows the 2 guidelines that we have that are active. The first is the CDC HHS Health and Human Services guidelines. That was done in 2021 before injectable cabotegravir was FDA approved. So they are working on an update, but no ETA on that. Then next to the right is the IAS USA guidelines. They unfortunately differ in a few places, which I'll try to point out to you, mostly in that the IAS USA guidelines are a little bit more permissive. And I'll read something that is their philosophy in one of these slides. Okay, so who should be prescribed PrEP? I'm going to go into this in detail because this is a little bit of the conversations you all are having and discussing and referring folks. So the recommendation and the those numbers and letters at the end relate to the strength of the recommendation and whether or not that is based on randomized clinical trials or expert opinions. So, and this may be switched, but so the one I believe refers to randomized clinical trial. A is strength of recommendations. Forgive me if I've reversed that in my mind. But so the 1, 2, 3 and ABC go from randomized clinical trial, observational trial to expert opinion, and the other being very strong, moderately, and sort of, a weak recommendation. So everybody should be talking about HIV testing. That was a recommendation from, 2006, that all adults between 13 and 64 should have at least one HIV test. All adults and adolescents, I should say. And then the new recommendation includes talking about HIV pre-exposure prophylaxis and making a decision about whether or not that's right for them. And I'll talk a little bit about how you make that decision in a later slide. In terms of which medicine, so both men and women and adolescents who are at least 35 kilos, which is about 75 pounds, that daily FTC TDF is the one that is recommended. It is also, that is the medicine recommended for folks who inject drugs and report practices that place them at substantial risk for HIV. There is a specific call out for discordant couples in the CDC HHS guidelines. One of the things that has also come to light over the last 10, 20 years is this idea of U equals U. So undetectable equals untransmittable. So someone who is HIV positive, who is on HIV medicines for a while and has an undetectable viral load, or a viral load that is below 200 copies per milliliter of blood, that they cannot transmit HIV. And so this idea of discordant partners is one where, in an ideal world, if someone is not yet to that 200 level, that PrEP should be prescribed to the HIV-negative partner in that partnership. If the person doesn't know their viral load, then PrEP should be prescribed. Sometimes the HIV-negative partner has other partners, but the interesting thing is this call out that says, if the HIV-negative partner wants the additional reassurance of additional protection beyond U equals U, that PrEP should be prescribed. And this is that sort of how you can assess people. This tug of war up here is my insertion into this figure that it comes from the CDC HHS guidelines. And this represents this tug of war that we have between trying to be good shepherds of our horribly out of crazy expensive medical system and trying to get resources to the people who need them the most, balanced with we really want to be the best advocates for our patients. And sometimes those are at odds with each other. But this is a little bit of what this slide sort of demonstrates. So the recommendation, and I know you had this conversation the last time, as the recommendation from the CDC HHS is this old question that is to start off this, how you ask a sexual history, how you take a sexual history is to start off with do you have sex with men, women, or both? This is an old question, and I do not recommend using this unless you are very uncomfortable asking and taking a sexual history. And I think it's just a good, it was something that I learned when I was in training 30 years ago. And it's really good to get you comfortable, right? Because if you're uncomfortable with a sexual history, then everybody else is going to be uncomfortable too. So this is an easy question. It doesn't recognize that there are people who may not identify as men or women, and it's disrespectful to individuals and their partners. I usually use a more open question, which is, tell me who you're having sex with and what are you doing with those folks? And they can use whatever words that they feel most comfortable with. And that is all okay. People should use the terminology that they are most comfortable with. But this is our algorithm. Please adapt it to be more appropriate and more accepting of folks who are gender non-binary and non-conforming. So once you've asked this question of who they're having sex with, the recommendation is to ask, Do you have anal or vaginal sex? Have you had anal or vaginal sex in the past 6 months? You may use this as back hole and front hole, depending on what words the person in front of you is using. If they say yes, you ask if they've had an HIV positive partner, if they've had any partners of unknown HIV status, or if they themselves have had a bacterial sexually transmitted infection, that's chlamydia, gonorrhea, or syphilis in the last 6 months. And you can go down here, and the recommendation in these dark green boxes is to prescribe PrEP if someone is at higher risk for acquiring HIV. But what is really interesting about this and really reflects this tug of war is that even if someone says they don't really have any of these markers for being someone who is more likely to test HIV positive, even if the answer is they haven't had sex in the last 6 months, that we're supposed to talk about PrEP and to prescribe it if it's requested. There are some times that I have said no to people but mostly that's because I've been able to explain to people what the risks of HIV acquisition are with what it is that they've been doing. There's a similar algorithm for folks who inject drugs, that really the risk is if you are injecting someone who has injected recently, and that you're sharing injection equipment. But again, if someone is saying, no, it's been a year since I've injected, but they really, really want to get on PrEP, the recommendation is to talk about it and to prescribe it, if that makes sense. Okay, this is a slide I'm going to skip. Oh, but I will read to you. This is why the recommendations between the CDC recommendations and the IAS HSS guidelines differ is, again, this permissiveness. So this is a statement in the IAS USA guidelines that the optimal PrEP regimen for a given person is the one that is most acceptable to that person and congruent with their sexual behavior, ability to take medicines reliably, likelihood of anticipating sexual activity, and adverse effect profile. Understanding that we have FDA approval for certain medicines in certain populations, but at least in places where things should work just as well, that we should allow people to make decisions and have autonomy over their own choices about their medical care and their sexual health. I'm going to skip that as well. I just want to say that there is really, if you are someone who is a prescriber, again, I'm not going to talk to you specifically as much during here, but there are these really nicely outlined recommendations for what blood work you should do, and what other tests that you should do. If you are someone that is talking and supporting, know that the recommendation is regular check-ins with their people's providers. I've heard some stories of people getting PrEP, their prescription for a year and not going back for a year. The recommendation is to do regular testing so that we can monitor kidney function and that we can monitor for STIs and test and treat people. Again, not going to go into details here. There is also a push for same-day prescribing for HIV pre-exposure prophylaxis. This is back when I started doing it in 2013. I would see people twice, do 2 different HIV tests, and only then prescribe. And what we've recognized in the last 10 plus years is that the people who are at risk for HIV are not going to use a condom for the next 2 weeks while you wait out the window period of your HIV test, and they either won't come back or they may get HIV in the interim. And there's been a shift towards getting people on PrEP same day, next day, really as soon as possible after they've decided that PrEP is right for them. So I've changed my practice as well, as long as there isn't something that's holding me back. And one of the things, this is from the CDC guidelines, the things that might limit someone to getting a PrEP on the same day that they say, yep, I want to be on PrEP, is someone who's not really sure, someone who you can't draw blood on, anybody with signs and symptoms that might be recent infection. And those are fever, rash, sore throat, muscle aches, flu-like illnesses. You want to wait until they get their HIV test results back before getting PrEP. someone with kidney disease or hypertension and diabetes, and someone who has no health insurance, you may not be able to get them PrEP that day. Gonna skip which are appropriate. This is a table that is in the CDC HSS guidelines, and I really want to point out that some of your folks may be taking St. John's wort as an over-the-counter, and there is an interaction with FTC-TAF. That's the newer medicine, just so you're aware of that. And then I'll say this, although it may not be as relevant, is that one of the things we're recognizing with injectable cabotegravir is that it can stick around for a long time. And there's a recommendation in the guidelines that if people are on the injectable medicine, and people are on the injectable medicine oftentimes because they don't want to be taking an oral pill every day, but there's a recommendation for people to take a tail, to continue once they've decided they're no longer to take the PrEP injections, to after a few months to go on pills so that they're protected while the levels of cabotegravir drop down to undetectable levels. And it can take about a year or even longer for those medicine levels, for the injectable to drop down to levels. And because the reason for concern is that if someone becomes HIV positive while there's a little bit of medicine still in their blood from their last injection, that they could develop drug resistance. And the class of medicines that the injectable PrEP is in is the one that we use most commonly to start people. You all probably know a lot more about how to support people in their medicine taking. The first things we do is just recognize that medicine taking can be a challenge. It's hard for people to change their behavior and do things every day. And so when people come in for visits, we try to normalize that PrEP medicine taking is hard. Many people find it difficult to take a medicine every day. And that there's no one right way to ask. People will often tell you that they're doing better on their medicines than they really are. So how many times in the last week or the month have you or have you not taken your medicine? You can frame that question any way you like. And just getting to the place where if someone says, I'm doing fine, it's always good to reinforce the taking a routine. PrEP just needs to be taken every day. It doesn't need to be taken at the same time every day. If someone says that they're having real challenges, then there are a couple different ways to approach that. It sort of depends on whether or not the pill taking issues are related to something that can be problem solved, like I just forget, and perhaps an alarm is something that could be helpful. If it's a motivational thing, I just don't want to take it, I don't like thinking about it, then you may need to do some more motivational interviewing related to that. But these are just some suggestions for how to talk about PrEP and how to make it easy for them. I usually do all the education with them during their visit, and then in thinking about their pill taking, just trying to reinforce getting into routine, whether it's the brushing their teeth at night, taking it with other pills, doing it with breakfast, their coffee, whatever it is, it's about establishing a routine, just like anything. And then being forgiving when people are report that they're having challenges, because there are, my last time I gave this talk, I talked about how hard it was for me to floss my teeth every night. Behaviors are hard, and establishing routines are hard. And so just being supportive of people can be really helpful. And there are a lot of things that we are doing in order to increase PrEP access and make it easier for people to get on and stay on PrEP. I know there's some folks here from some of our lower barrier care clinics where people can walk in. One of the good things about that came out of the COVID pandemic is how comfortable many people, not everyone, but many people are with telehealth. PrEP is one of those great things that can be done by telehealth. You can get your medicines in the mail. You can even send in blood tests via mail. There are mobile clinics around the country. Some places have vans that will go around because you don't want to be seen in the clinic in your town. And then there are pharmacies. I'm involved with a pharmacy project right now to try and expand pharmacy-based PrEP across the country, where someone can walk into a pharmacist who's trained in how to do PrEP and not have to go to an HIV clinic or an STI clinic, sexual health clinic, in order to get PrEP. And there's a real big push in the president's plan for HIV to expand pharmacies and pharmacy-based PrEP. As I mentioned before, we're trying to integrate PrEP with gender-affirming care, as well as places where there is syringe exchange and other harm reduction services. Skip this. Paying is one of the biggest concerns. The United States Preventive Services Task Force that was most recently updated last year gave PrEP a grade A recommendation, which at least currently says that all private health plans must cover PrEP without cost sharing. Although they're allowed to institute copays and coinsurance and prior authorizations, and depending on the state, it depends on some states require no copays or cost sharing, regardless of which PrEP medicine is. Some require it only for the generic, that there should be no cost sharing. Although I'm sure many of you know that there is a case that is making its way to the Supreme Court, that will make its way to the Supreme Court, that will allow plans to get exemptions from this. I think very few of you need to know this is just about IZT-10 codes. There's a new PrEP billing code. We are really lucky here in the state of Washington that there is a PrEP drug assistance program. This exists in other states like California and Colorado, I'm aware of. There may be states, a state drug assistance program in your state. There are other medication assistance programs that are not specific to PrEP that exist, although oftentimes they run out of funds before the end of the year. And then just to wrap up, there are still some questions that have no answers. So one is, how long does it take to achieve protection on PrEP? Well, we know that you achieve maximal levels of FTC-TDF in 7 days in the rectal tissues and 21 days in the rest of the body, but we don't know how long it is before someone can feel protected. We don't know what the tail is for someone, how long someone needs to take PrEP after their last exposure, if they've been taking oral PrEP. We're just starting to see implementation of injectable PrEP. I think many people were really excited about this, and we're just slow to implement now. And then looking at what's going to happen with healthcare insurance, I think is a big question for us as we move forward. There are a lot of medicines that are coming down, like birth control. The more options you have, the better choices people will make, and the better the choices that are right for them. The vaginal ring is probably going to come back, probably paired with perhaps contraception. There are other injectables. We're waiting on a study that hopefully will be reporting results within the next year for a every 6-month injection instead of this every 2-month. So it's really exciting time to be in this field. There's a lot that's going to be happening. So just stay tuned for that. And I'm going to skip this DoxyPEP, show you that I have some resources in here. If you have questions, you are always welcome to reach out to me if you have any questions. Want to acknowledge the Mountain West AETC who provides support to me. And I'm going to end. I'll take questions.
Thank you so much, Joanne. Getting things here set up on my end, so I apologize. All right. I appreciate the presentation. I was busily writing things down as you were talking, so thank you so much for just kind of personalizing all of this information and big data to behavioral health workforce and those who work in maybe outpatient or inpatient settings, because I know that there is a lot of kind of overhead and data, but it is important to look at those other things about talking to our clients, just, you know, those small things of if they come in and they're not feeling well, are they taking food with their medications, or the different types of medications, just so that we know about them or how they're taken. And it's just so important, I think, to reach out to places in our community that provide PEP and PrEP, and to see if they have resources or flyers or anything that we can bring back to our agencies. So thank you. We do have some questions, so I'm not sure, some may have been answered during your presentation, but we're just going to go through them again just for clarification. The first one is clarifying question. It asks, taking these medications, is it implied that there is a cure for HIV, or persons taking these medications properly do not contract HIV?
Yeah, great. That's a great question. So to date, there have been, I believe, only 2 people who have been truly cured of HIV, and that is through a bone marrow transplant. So that is not what these medicines do. With HIV medicines, people can live normal lives. I have HIV patients who climb mountains and run marathons and do all sorts of things. But when taken appropriately, these HIV medicines, as for HIV negative folks, can prevent not quite 100%, but nearly 100%. Not nearly 100% can prevent them from acquiring HIV.
Great, thank you. Then there's a couple questions. I didn't want to interrupt you at the very beginning regarding the study at the very beginning. So we'll go back to that. For the efficacy trials, are blood percent of TDF low because of poor adherence, or how the medication is processed in their body?
Yeah, and that's a great question, because that, I think, was some of the concerns that we had until recently, with this recent manuscript done by Dr. Marazzo. So when those original trials were done and showed no efficacy in cisgender women in those 2 large trials, but there were other cisgender women in some of the other trials, like the Partners PrEP trial, where PrEP was shown to work. So I think we knew that at least some of it was due to medicine taking. But we couldn't exclude the possibility that there was some biologic reason why maybe you needed to take more pills per week in order to get adequate levels where cisgender women might be at risk. So is the cervical vaginal area different than rectal tissues? And what Dr. Marazzo's paper would suggest is that it's really about adherence, much more about adherence, and very little to do with the biologic differences between men and.
Okay. So I think it may answer the next question.
Yeah.
Somebody was also asking, is this data saying that this medication is less effective in women, and why is that?
I'm not sure if that was related to that oral, the oral PrEP question, or if that was related to injectable cabotegravir in terms of medications. Mm-hmm. There's, I think, no reason to think that either one of those 2 is less effective in women.
Right. And someone is asking, we do have a little bit of time, so they would love to hear a bit about doxy PrEP, if there's time.
Yeah, so it's post-exposure prophylaxis using doxycycline, which is a common antibiotic that we've had around forever. And there was a suggestion that giving doxycycline after someone had a sexual exposure could prevent bacterial infections, particularly there was concern about syphilis, and I think in the original trial it was chlamydia, but not gonorrhea, just because there's increasing resistance to gonorrhea. Forgive me if I'm wrong about that specifically, but there was a large randomized trial. There were several large randomized trials that were just recently done. One that was done in cisgender men who have sex with men, that showed efficacy of giving doxy-PEP as bacterial STI prophylaxis, was able to reduce all 3 STIs. The concern, of course, is that there's going to be some change in people's the microbiome, that we're going to develop more drug resistance. Although, of course, we give doxycycline regularly for people with skin issues and things like that. Also, interestingly, there was a large study that was done in cisgender women that, so like with HIV PrEP, didn't show any efficacy at all, probably due to adherence, people's pill taking, that they weren't, but that data hasn't been released yet. The CDC, I think it's now 2 weeks ago, just put out guidelines for the use of doxypep, and it is recommended for anybody, particularly men who have sex, cisgender men who have sex with men, who has had a bacterial STI, I believe in the last year, you can prescribe for someone who is a cisgender man who has sex with men who has not had an STI in the last year, and as well as this permissibility that I've never seen from the CDC, but I think it's probably because it's a different branch doing the STI recommendations rather than the HIV recommendations, but saying that even though the data suggests that there was no benefit in cisgender women, that there's no biologic reason to think that there is a difference. And so it may be prescribed in women who are at risk for STIs also. That's the not too short answer to what doxypep is.
Thank you. And I had a question really quickly, and please do others write in questions if you have them. Oh, I see, Lydia, I see your hand is raised. Did you want to chime in here real quick?
Yeah, I do have a question. You can ask your
go for it.
question too, Amy.
No, yeah, go for it.
I'm curious, Joanne, as a psychiatrist who works at our county hospital and sees patients, we've been thinking about building capacity within behavioral health organizations for PrEP. And there are challenges, I think, in our settings in initiation, but mostly in the ongoing monitoring, maintaining people on PrEP. And so one model that's been suggested is that we can assess and maybe start and then refer, or just assess and refer, but potentially assess and start the medication and then refer somebody for maintenance. And I'm just wondering if you can comment on, kind of the risks, the downside of us starting if we're not going to be able to maintain, just how we might think about different models of what you think, as an HIV physician, what you think could be happening in behavioral health organizations.
Yeah, I think that's a great question. My clinic that I started at one of our local community organizations was a model just like that, because it's actually, I will say this, the hardest part is having that initial conversation. PrEP monitoring is really quite easy, but it's having that conversation with someone, not that it's hard, right? But that's what, when we started doing this 12 years ago, that's what primary care providers were they didn't want to have that original conversation. But once I had decided that someone was right for PrEP, they were perfectly happy checking boxes and doing a HIV test every 3 months and a STI, right? I mean, they were totally fine with that. So the model, I think, is fine if that's what you would like to do. There are different ways of, where that referral point goes to. Does that referral point go to a primary care setting? Does that referral point go to a pharmacy that you're paired with? That's an easy enough thing to do. If there's a pharmacy that you can partner with, it's always better, in my experience, to partner with pharmacies that know what they're doing around PrEP medications, just because there are some, with the patient drug assistance and all the support, that it's helpful to have pharmacists who know the system as well as possible and are willing to help you, just because sometimes commercial pharmacies aren't interested in doing all the extra work to try and go through the prior authorizations or do the patient assistance programs. But I also think, like, if you're going to have that initial conversation with someone and you have the capacity to start somebody, why not continue it? Just because, again, it's continuity is actually the easy part.
Just a quick follow-up question about pharmacy, because I think for some of our more rural and frontier, colleagues in rural and frontier settings, pharmacies may be a good option. Do you have a general resource for pharmacies that is that how common is that for pharmacies to be able to offer PrEP? Is that very location dependent, or is there a general resource where that might be available?
So the laws differ from every state. Joys of, insurance differs in every state, laws differ in every state. In some states, pharmacists have the capability of being completely independent from any sort of physician or other provider backup. In Washington State, where the whole thing started, we don't actually have a law that lets us do that, but what we have is something called a collaborative drug therapy agreement. There are some variations of what that term is, where I have been medical director, I'll put that in quotes, of, say our local Kelly Ross pharmacy, and we do check-ins of their patients, but they operate as prescribers. They can bill in Washington State all the different insurances. Again, every insurance is different. Everything changes all the time. But if anybody has interest in exploring this more, I have a side project. Thank you for that. I don't know if that was a plant there. That is trying to help pharmacists who are interested in developing their skills in order to be able to start up pharmacy-based PrEP clinics. And I would be happy to talk with either the pharmacy, if there are any pharmacists here, or there are people who want to work with pharmacists and trying to figure out how the best way to do that. And I don't know, Lydia, Amy, if my email went out, I'm happy to respond to emails if people want to connect with me around that.
Yeah, we can definitely do that. Thank you. Anything else, Lydia? They're all great questions.
Now, I think if other folks have questions, they can put them in the Q&A or put them in the chat. A lot of information. We really appreciate it. It's really helpful resources we're thinking about expanding. People want to share their experiences in the chat. We have a couple of minutes for one or two more questions, maybe.
I'm sort of wondering whether we should reopen the poll and ask people if they have a difference in what they perceive. Did I convince anybody who's thought there was no role for them if now they have a role? I don't know. If anybody wants to volunteer stuff in the chat, I'd love to hear it. Is anybody going to do anything differently after this talk?
There are some in the chat. Someone is saying Walgreens in states do HIV testing.
Yes. Yeah. And I think that's a first step for many pharmacies, is to offer HIV testing. No one is brave enough to say how they're going to change.
We do not have that.
We're working on it, Joanne. That's a heavy lift for those of us in behavioral health, but we're working on it.
I can say one of the things. Oh, whoops, we have.
Yeah, that comment about significant benefit, even if patients aren't 100% compliant, I think that is really eye-opening, right? I mean, we sort of have had this paternalistic view of HIV medicines at the beginning. Like, if you were someone who injected drugs, we weren't going to prescribe medicines for you because you'd screw up and get drug resistance. And that, that has changed. And so I think that is true for PrEP too, that, that there is a benefit, even if people acknowledge that they're going to have challenges. And I think that that's something as provider, right? We're doing harm reduction. The goal is to try and decrease the risk of bad outcomes and not put our, you must wear a condom every time sort of behavior.
People are just saying thank you for helping them understand it better. And I think I was going to say too, along the lines of, people taking their medications. I think something that I will change definitely is asking how to ask people, are they taking their medications? I think you had said, how many times have you taken it or not taken it in the past week? Is so less demeaning than have you been compliant with your medications, or the way that we've been taught, how to say it.
Yeah. And for PrEP, it's sort of, and there's no reason it's specific to PrEP, but all of them are sort of pretty similar. And the framing is just, how many times have you not taken it versus if you want to be positive, how many times did you take your PrEP this week? It's easier to do that for a week than for a month, right? I mean, like, how many times did you, like, that's sort of hard to remember. And then there's a qualitative one that is, how in general have you been, excellent, very good. But I never really know what those words mean when people sort of do qualitative stuff. So I always like the number. How many times have you missed in the last week?
Yeah, no, the presentation was great, Joanne. We had a nice size audience and a good number of people joining. I think, really the recognition that people with serious mental illnesses are disproportionately, at increased risk of acquiring HIV and clearly at increased risk of not being offered PrEP, that we really do need to sort of step up and help fill that gap a little bit. And, why aren't people being offered? Why aren't they being assessed? Is it a level of discomfort of taking a sexual history? And what should behavioral health providers be doing? So that, that's the point of this series, but really thinking about people's, what are local resources and how do you connect with resources? So, kind of people, there's some interesting comments in the chat as well. Kind of thinking about sort of, diversity of staff members and whether, kind of these discussions are falling on providers who are more open to those discussions. Should we be more systematic and routine in our assessment? I think is another.
Yeah, I mean, one of the things back when I attended with on the inpatient service, that I always made sure that my medical students asked sexual histories as part of intake histories, because it's sexual health is part of health. And so if we sort of put it into a corner and say it's only for those times, and it becomes much more uncomfortable for us, and then we never get out of. So I would encourage, sort of as part of routine intake, that there are some basic questions asked about sexual health. I'm not going to get into are you enjoying your sexual life, right? Like that's one that I don't think even our sexual health clinic doesn't do. We should be enjoying our sexual health and our sexual lives, but that is, I think, as providers, none of us feel comfortable talking. Fewer of us feel comfortable talking about.
Okay,
Thank you.
That
Go ahead.
Peyton put the link to the evaluation, if folks will do that before they hop off.
I'm going to go ahead and share my screen and put that QR code up as well, so we have that. So that is up on the screen.
I want to thank you again, Joanne. This was great. It was a great presentation. Really, really helpful information. So thanks for sharing all the resources.
You're welcome. Thank you for having me. Hopefully it was sort of helpful in the right ways.
Absolutely. And thank you everybody so much for being here today, taking the time out of your day. We really do appreciate it. And please check out our website and join us for future presentations. And again, please look for that July sexual health series. It will be the last in our 4-part series on July 16th.
And check out the AETC website. Lots of great resources there as well.
Thank you so much, everybody, and we will see you again soon.